Chronic bronchitis is a subtype of chronic obstructive pulmonary disease. Chronic bronchitis usually develops in chronic smokers and characterized by excessive deposition of mucus in the airways. Chronic bronchitis has three major symptoms. It's dyspnea, chronic cough, and sputum production. So to explain the pathogenesis of chronic bronchitis, here we have a pulmonary compartment with bronchi and alveoli. And also we have blood compartment. For example, if we take inspiration, the airflow on inspiration is equal to pressure in external environment minus pressure inside the alveoli divided on resistance of the airways. And resistance is inversely proportional to the force power of radius of the bronchi. And once air full with oxygen income to the alveoli, oxygen diffuse through the alveolar membrane into the capillary, and after red blood cells deliver oxygen to the peripheral tissues. In exchange from the capillaries, carbon dioxide diffuse into the alveoli. And as we know, the most oxygen-dependent tissues are brain tissue and myocardial tissue. During smoking, smoke chemically irritates goblet cells and submucosal glands. It's mucus-producing cells that cover our airways. In response to irritation, goblet cells and submucosal glands produce mucus that should protect our airways from the smoke. And the higher the amount of smoke that income to the airways, the higher the mucus production. Because of this, in chronic smokers, chronic irritation by smoking causes massive secretion and deposition of mucus in the lumen of the airways. To partially remove mucus, we activate ciliary clearance. Simply speaking, we begin to cough, and by coughing, we can get rid of mucus. So chronic smoking leads to a chronic productive cough. The major problem is that our lung clearance is quite limited, but mucus hypersecretion do not have any limits. And when mucus secretion prevails over ciliary clearance, mucus begin to accumulate in the airways. As a result, deposition of mucus causes an obstruction to the airflow. With obstruction, radius of the bronchi decrease. With decrease in radius, resistance increase, and with increase in resistance, airflow decrease. So obstruction causes decrease in income of oxygen to the alveoli. With decrease in oxygen concentration in alveoli, oxygen diffusion decrease. As a result, the concentration of oxygen in the blood decrease, and we call this state hypoxemia. In response to local hypoxia, endothelial cells of the pulmonary capillaries begin to constrict. The problem is that at some point vasoconstriction becomes so severe that it causes accumulation of fluid in the pulmonary arteries. The higher the volume of fluid in the pulmonary arteries, the higher the pulmonary hydrostatic pressure, and increase in pulmonary hydrostatic pressure we call pulmonary hypertension. In response to decrease in oxygen concentration in the blood, our chemoreceptors begin to stimulate breathing center. This results in increase in respiratory rate. With increase in respiratory rate, intercostal muscles should work harder, and frequent isometric contractions of the intercostal muscles cause feeling of chest tightness. The lower the oxygen concentration in the blood, the lower the oxygen delivery to the tissues. The most sensitive tissues to hypoxia are brain tissue and myocardial tissue. Decrease in oxygen delivery to the brain tissue cause symptoms as weakness, fatigue, and lightheadedness. Decrease in oxygen delivery to myocardial tissue cause myocardial ischemia that initially decrease exercise tolerance and then cause angina symptoms as retrosternal pain, for example. In order to provide enough amount of oxygen to peripheral tissues, especially with physical exercises, we need to further increase the respiratory rate. And such a severe increase in respiratory rate manifests as shortness of breath, or we call this symptom dyspnea. In response to decrease in oxygen concentration, kidneys begin to produce more erythropoietin that stimulates the production of red blood cells. With increase in red blood cells, the concentration of hemoglobin increase, so secondary polycythemia develops. Also, deposition of mucus creates the perfect environment for bacteria. As a result, the risk of bacterial infections greatly increase, and this can cause frequent pneumonias. Because mucus obstructs the airways, airflow instead of lamina becomes turbulent, and turbulent airflow produces vibration sound that we call wheezing. And also, obstruction by the mucus will cause decrease in airflow that we can determine by decrease in forced expiratory volume in 1 second and by decrease in FVV-FVC ratio. To explain this, there is a graph. In this graph, we see volume and time. As we breathe out as fast as we can, in normal condition, we breathe out over 80% of air during the 1 second, and then we exhale other 20 during the next 4-5 seconds, and in the end we get so-called forced vital capacity, which is the maximal volume of air that we can exhale. The amount of air that we can breathe out as fast as possible in 1 second we call forced expiratory volume. During exhalation, the airflow is equal to pressure inside the alveoli minus pressure in external environment divided on resistance created by the airways, and resistance is inversely proportional to the force power of radius. So from this formula we see that airflow is determined by the radius of the airways. In chronic bronchitis, deposition of mucus causes decrease in radius of the bronchi. With decrease in radius, resistance increase. With increase in resistance, airflow decrease. And we can see this on a graph. Now in 1 second, instead of 80% of air, a person can breathe out only 65, and forced vital capacity remains practically the same. Let's suppose that obstruction becomes more severe. So radius decrease even further. With decrease in radius, resistance increase, and with increase in resistance, airflow decrease. And now in 1 second, a person can breathe out only 40%. So in chronic bronchitis, we can determine the severity of the obstruction by decrease in forced expiratory volume in 1 second. And also, because FEV1 decrease and forced vital capacity remains practically the same, the ratio of FEV1 to FVC will decrease, and it's the second value that we can use to determine the severity of the obstruction. Also, we have to know that chronic bronchitis is a progressive disease that gradually gets worse over time. In simple terms, once mucus appears in the bronchi, mucus won't disappear, which is more likely. With chronic smoking, mucus will only accumulate, and thereby obstruction with time will get even worse. So there is no step back, but there is always step forward.